Have you ever, like, stopped to think about just what an incredible symphony is happening inside your chest right now? Not your latest Spotify playlist,
Yeah.
but the rhythmic beating of your heart.
Right.
Yeah, it's working tirelessly 24/7,
Yeah.
pumping life-giving blood throughout your body. We kind of just take this for granted, but understanding how this powerful pump functions is really key to understanding our own health and well-being.
Absolutely.
Today, we're going on a deep dive into this fascinating world of the cardiac cycle,
All right.
to the sequence of events that makes up just a single heartbeat.
It's quite amazing how this really complex process unfolds with each beat, ensuring that oxygen and nutrients get to each and every cell in our body.
And to help us explore this today, we have some fantastic educational material from the London HeartbeatsZ Academy in the UK.
Right.
Huge thanks to them for providing some really detailed insights.
Fantastic.
And listeners, don't forget to follow us on Facebook, Instagram, Spotify, and YouTube to stay updated on future episodes and explore even more fascinating topics.
Yeah.
Now, to kick off our deep dive,
Okay.
let's start by just defining the cardiac cycle. What exactly are we talking about here?
The cardiac cycle basically encompasses all of the events that occur from the beginning of one heartbeat to the beginning of the next. It's just a continuous rhythmic cycle of contraction and relaxation that keeps blood flowing throughout the body.
So it's not just about the lub-dub sound that we hear.
Yeah.
There's a lot more going on behind the scenes.
Absolutely.
Yeah.
The lub-dub is simply the audible manifestation of this really complex series of electrical and mechanical events that make up each heartbeat.
Okay, that makes sense. Now, we know that the heart is a pump,
Yes.
but can you break down the roles of the different chambers?
So think of it this way.
Okay.
The atria are like little prep stations.
Okay.
They receive blood from the body and lungs and then efficiently pass it down to the ventricles. The ventricles are the powerhouses. They propel the blood out to the rest of the body and the lungs.
So it's a two-step process. Atria first, then ventricles.
Precisely. And the whole process is orchestrated by the heart's natural pacemaker, the SA node, located in the right atrium.
Right.
Sends out an electrical impulse that sets the entire cycle in motion.
That electrical system sounds pretty crucial. Can we delve a little deeper into that?
Absolutely. So the electrical conduction system is like the control center of the heart.
Okay.
So the impulse starts at the SA node,
Okay.
travels through the atria, and then reaches the AV node, where
Okay.
things get a little bit interesting.
Yeah.
There's a slight delay at the AV node, about 0.13 seconds,
Really?
before the signal is passed on to the ventricles.
Why would we want a delay in the signal?
Yeah.
Wouldn't we want it to travel like as quickly as possible?
This delay is essential because it allows the atria to fully empty their blood into the ventricles before the powerful ventricular contraction begins.
Okay.
It's all about timing and efficiency.
So the atria need to finish their job before the ventricles take over.
Exactly.
That makes sense. But what causes this delay at the AV node?
So the AV node has a really unique structure. It has fewer gap junctions compared to other parts of the conduction system. Gap junctions are like tiny tunnels that allow the electrical signal to pass from cell to cell.
Oh, okay.
So fewer gap junctions in the AV node means slower transmission of the electrical signal, leading to that crucial delay.
So the structure of these like tiny junctions actually dictates the timing of our entire heartbeat.
Absolutely.
That's incredible. But then how does the signal get to the ventricles so rapidly after the delay?
So that's where the Purkinje fibers come in.
Okay.
They're specialized fibers that spread the electrical impulse throughout the ventricles at an amazing speed,
Wow.
up to 4 meters per second.
That is so fast, especially compared to that slow crawl through the AV node.
Yeah.
It's amazing how the heart is designed for both precision and speed. So we've covered the electrical system. What about the actual mechanical events of the heartbeat? How does all this electrical activity translate into the pumping action that we associate with the heart?
Yeah, now we're talking about the phases of the cardiac cycle.
Okay.
A beautifully choreographed dance of pressure, volume, and blood flow within the ventricles. So to simplify things, we'll mainly focus on the left ventricle since it's responsible for pumping oxygenated blood to the entire body.
Okay, left ventricle it is. So how does this dance begin?
So let's start with atrial systole.
Okay.
Remember, the atria act as primer pumps?
Yeah.
During atrial systole, the atria contract, giving that final push of blood into the ventricles.
So the ventricles are already partially filled.
Correct.
And the atria just kind of give that little extra boost.
Exactly. This atrial kick is reflected on the ECG as a little blip called the A wave,
Okay.
representing the electrical activity of the atria contracting. And as the atria contract, the pressure in the left ventricle increases slightly,
Right.
and the volume reaches its maximum, which we call the end diastolic volume, or EDV. It's usually around 120 milliliters, so basically the ventricle's full capacity.
EDV. Got it. So what happens if this A wave looks abnormal on an ECG?
Great question. So an abnormal A wave can be a sign of various heart conditions.
Right.
For instance, a very pronounced A wave, sometimes called a Cannon wave,
Okay.
can indicate problems with the timing of the heartbeat, like a heart block.
Well, wow.
On the other hand, a weak or absent O wave might suggest atrial fibrillation, where the atria are quivering instead of contracting effectively.
So doctors can use these like subtle clues to kind of figure out what's going on with the heart.
Exactly. It's like piecing together a puzzle.
Hmm.
Each detail, even the shape of a wave on an ECG,
Right.
can provide valuable insights. Now, moving on from atrial systole,
Okay.
the next phase is isovolumetric contraction.
Okay, break that down for me. What does isovolumetric even mean?
So isovolumetric means constant volume.
Okay.
In this phase, the ventricles start contracting,
Oh.
but all the valves are closed, so the blood inside has nowhere to go. This causes the pressure inside the ventricle to rise rapidly.
Well, it's like squeezing a closed water bottle. The pressure builds up, but the volume stays the same.
Perfect analogy.
Mm.
This pressure buildup is crucial because it forces the aortic valve to open, allowing blood to be ejected into the aorta.
Okay.
And remember those mitral and tricuspid valves?
Yeah.
They close when the ventricular pressure exceeds atrial pressure, preventing blood from flowing back into the atria. This closure creates the first heart sound, the lub we hear.
Ah, the famous lub. But I've heard that it can sometimes be split into two sounds. Why is that?
So that's because the mitral valve usually closes slightly before the tricuspid valve.
Really?
It's a very subtle difference, but trained ears can often pick it up, especially during inspiration.
Wow, so much information packed into just a single lub. What else is happening during this phase?
Another interesting phenomenon is LV torsion, where the left ventricle twists as it contracts,
Right.
increasing its efficiency.
Hmm.
It's like wringing out a towel. That twisting motion helps expel more blood.
So we have rising pressure, closed valves,
Right.
the first heart sound, and this twisting motion all happening like in a fraction of a second.
It's quite amazing.
What's next in this intricate cardiac dance?
So the next phase is rapid ejection, where the pressure in the ventricle continues to rise until it exceeds the pressure in the aorta.
Huh?
This pressure difference forces the aortic valve open, and blood is rapidly ejected out of the ventricle and into the aorta.
So it's like a dam bursting open. What's happening on the ECG during this time?
So the QRS complex, which represents ventricular depolarization, has already occurred,
Okay.
marking the beginning of ventricular systole. During rapid ejection itself, there aren't any specific ECG changes. It's mainly a mechanical event.
Got it. No new electrical signals, just the mechanical action of blood rushing out.
Mm-hmm.
But we're not done with ejection yet, right? There's more to the story.
You're right.
Yeah.
After rapid ejection comes slow ejection. So in this phase, the blood flow from the left ventricle to the aorta starts to diminish. But it's kept going by something called the Windkessel effect.
Windkessel effect.
Yeah.
That sounds complicated.
It's actually a fairly simple concept. Think of the aorta as a stretched rubber band.
Okay.
When blood is rapidly ejected into it, the aorta stretches, storing some of the energy. Then, during slow ejection, the aorta recoils, pushing the remaining blood out, just like a stretched rubber band snapping back.
Ah, so the aorta acts like a secondary pump, ensuring continuous blood flow.
Exactly.
That is so cool.
It's a remarkable example of the body's efficiency.
Yeah.
And finally, at the end of slow ejection, the aortic valve closes, marking the end of systole, the contraction phase.
Okay, so that brings us to diastole,
Yes.
the relaxation phase. What happens first during diastole?
So the first phase of diastole is called isovolumetric relaxation.
Okay.
As the name suggests, the volume of blood in the ventricle remains constant because all the valves are closed again. But now the ventricle is relaxing, so the pressure inside drops rapidly.
So it's the opposite of isovolumetric contraction.
Yes.
Same volume,
Mm.
but decreasing pressure instead of increasing. This pressure drop must be pretty dramatic, right?
Absolutely. The left ventricular pressure drops from around 100 mmHg to about 20 mmHg in this phase.
Wow.
And this rapid closure of the aortic valve creates the second heart sound, the dub we hear.
Lub-dub. We're really putting together the symphony of the heart here.
We are.
Is the second heart sound ever split, like the first one?
It can be. Just like the first heart sound, the second heart sound can also be split because the aortic valve usually closes slightly before the pulmonic valve.
Oh, okay.
Again, this normal splitting is most noticeable during inspiration.
Interesting. So even the timing of these sounds can give us valuable information about the heart's function. Anything else happening during isovolumetric relaxation?
Yes. As the ventricles are relaxing, the atria have been filling up with blood, getting ready for their turn to empty. This buildup of blood in the atria creates a small pressure wave that can actually be seen in the jugular veins.
Really?
It's called the V wave.
So we can see pressure changes in the heart reflected in the neck veins.
Yes!
That's fascinating.
It is. This V wave is a valuable clinical sign that doctors use to assess the function of the right side of the heart.
Okay, so we've got the aortic valve closing, the dub sound, the V wave in the jugular veins, and the ventricle relaxing. What happens next?
So the next phase is rapid inflow, also known as rapid ventricular filling. Once the pressure in the ventricle falls below the pressure in the atrium, the mitral valve opens and blood rushes from the atrium into the ventricle.
Like the floodgates opening. But the ventricular pressure continues to decrease even though blood is flowing in.
Exactly. This happens because the ventricle is still relaxing. This rapid inflow is also associated with a noticeable dip in the jugular venous pressure called the Y descent.
So the neck veins really are giving us a window into what's happening inside the heart. Are there any special heart sounds associated with this phase?
Yes. Sometimes a third heart sound, or S3, can be heard during rapid ventricular filling. It's a low-frequency sound thought to be caused by the sudden tensing of the chordae tendineae, the heartstrings that anchor the mitral valve.
Is this S3 sound a cause for concern?
It depends. While S3 can be normal in children and young adults, in older adults, it can sometimes indicate a problem with the heart's ability to relax and fill properly, like in heart failure.
So even subtle sounds can provide valuable clues about the heart's health.
Yes.
What happens after this rapid inflow?
The next phase is called diastasis, a period of slower ventricular filling where the remaining blood in the atrium slowly flows into the ventricle. There aren't any specific ECG changes or heart sounds during this phase. It's just a brief moment of relative calm before the cycle starts all over again.
So it's like a pause before the next heartbeat.
Exactly. And while all this is happening in the ventricles, the atria are already starting to fill up again, preparing for the next cycle. It's a continuous, beautifully synchronized process.
It is truly amazing how all of these events work together to keep the blood flowing. Before we move on, can we talk about the different volumes involved in this intricate process?
Of course. So there are 3 key volumes to keep in mind. End-diastolic volume, EDV, which we've already discussed. Stroke volume, SV, which is the amount of blood ejected from the ventricle with each heartbeat. And end-systolic volume, ESV, which is the amount of blood left in the ventricle after contraction.
So EDV is the whole tank, SV is what's pumped out, and ESV is what's left over.
Exactly.
How are these volumes related to the phases we just discussed?
So the EDV is reached at the end of diastole, just before the ventricle starts contracting. Then, during systole, the ventricle ejects a certain amount of blood, which is the stroke volume. And finally, at the end of systole, the remaining blood in the ventricle is the ESV.
And what are typical values for these volumes in a healthy heart?
So in a healthy heart, the EDV is around 120 milliliters. The stroke volume is about 70 milliliters. And the ESV is around a 50 milliliter.
So the heart pumps out a little over half of the blood it contains with each beat.
That's right. These volumes can vary depending on factors like heart rate, exercise, and overall health.
That makes sense. Is there a way to visualize the relationship between these pressure and volume changes throughout the cardiac cycle?
Yes. There's a graphical representation called the pressure-volume loop. It's a closed loop that shows how the pressure and volume in the ventricle change throughout a single heartbeat.
So it's like a map of the cardiac cycle.
Exactly. It's a very powerful tool that helps us understand the heart's pumping mechanics. And what's interesting is that the right ventricle, which pumps blood to the lungs, has a simile pressure volume loop, but it operates at much lower pressures than the left ventricle.
That makes sense, since the lungs are much closer to the heart than the rest of the body. Speaking of the right ventricle, are there any other key differences between the right and left ventricles?
So besides the pressure differences, the rate of pressure development, also known as DPDT, is significantly lower in the right ventricle. This reflects the fact that the right ventricle doesn't have to work as hard to pump blood to the lungs compared to the left ventricle pumping blood to the entire body.
So the left ventricle is truly the powerhouse.
It is.
Are there any differences in the timing of events between the two ventricles?
Yes. So the events on the right side of the heart actually occur slightly later than those on the left. For example, the tricuspid valve opens before the mitral valve. Okay.
And the pulmonic valve closes after the aortic valve.
It's like a slight delay on the right side. It's incredible how everything is coordinated yet slightly different.
It is.
Speaking of coordination, before we wrap up this part of our deep dive, I have to share a fascinating story about the history of cardiac catheterization.
Right.
It all started with a daring young doctor named Werner Forsman.
So back in 1929, Dr. Werner Forsman, a young surgical resident, was completely captivated by this idea of directly accessing the heart. He believed that a thin catheter could be safely threaded through a vein all the way into the heart.
Wow.
Opening up all these new possibilities for diagnosis and treatment.
That sounds incredibly innovative for the time. I can only imagine how his colleagues reacted to that idea.
You're right, cardiac catheterization was considered incredibly risky back then.
Yeah.
Many in the medical community even thought it was impossible.
Really?
But Forsman was determined to prove them wrong. So to test his theory, he took a rather bold step.
He decided to experiment on himself.
Wait, he performed the first cardiac catheterization on himself?
He did.
Wow.
He managed to convince a nurse to assist him, but she became frightened and left before the catheter reached his heart.
Oh, no.
But unfazed Forsman pressed on, guiding the catheter all the way into his right ventricle, all while using an X-ray machine to monitor its progress.
That's incredible. What a story. What happened after this self-experiment?
Well, he succeeded in proving that cardiac catheterization was possible and relatively safe. But sadly, his daring feat was met with resistance.
You're kidding, after such a groundbreaking achievement.
It's true. He faced skepticism and even ridicule from many in the medical community.
Oh, wow.
Ultimately, he lost his job and was essentially ostracized from academic medicine.
That's disheartening to hear. His work was clearly ahead of its time.
Yeah.
But his contribution to medicine couldn't be ignored forever, right?
Absolutely not. Years later, other researchers, particularly Dr. Andre Cornund and Dr. Dickinson Richards Jr., built upon Forsman's pioneering work. They refined the technique and demonstrated its immense value for diagnosing and treating various heart conditions.
So justice was served eventually.
Yes, thankfully.
Yeah.
In 1956, Forsman, Cornund, and Richards were jointly awarded the Nobel Prize in Physiology or Medicine.
Wow.
For their contributions to cardiac catheterization.
Talk about a comeback story.
Yeah.
It really goes to show the importance of challenging the status quo and pushing boundaries in medicine.
Absolutely.
Okay, now that we've explored that fascinating piece of medical history,
Yeah.
Are you ready to put our listeners to the test?
Absolutely. Let's see how much they've absorbed about the intricacies of the cardiac cycle.
Okay.
Get ready for a quiz, listeners.
Here are 10 multiple-choice questions to challenge your understanding of what we've discussed so far. No peeking at your notes.
Okay.
Okay, first question. Which letter on the pressure-volume loop indicates the point where the mitral valve opens?
Question 2. In a normal cardiac cycle, which of the following is true? A. Right atrial ejection precedes left atrial ejection. B. Right ventricular contraction starts before left ventricular contraction. C. Left ventricular ejection starts before right ventricular ejection. Or D. The pulmonic valve closes before the aortic valve.
Question 3. Which letter on the pressure-volume loop represents isovolumetric contraction of the left ventricle?
Question 4. Which of the following pairs is incorrect? A. P-wave atrial depolarization. B. QRS complex ventricular depolarization. C. T-wave ventricular repolarization. Or D. QT interval measure of the duration of the atrial action potential.
Question 5. The isovolumetric contraction phase corresponds to which of the following valve events? A. Aortic valve opening to aortic valve closure. B. Mitral valve closure to mitral valve opening. C. Mitral valve closure to aortic valve opening. Or D. Aortic valve opening to mitral valve opening.
Question 6. What is the typical left ventricular end diastolic volume in a healthy heart? A. 30 to 50 milliliters. B. 50 to 7 milliliters. C. 70 to 120 milliliters. Or D. 120 to 150 milliliters.
Question 7. A. Prominent Y descent in jugular venous pressure is seen in all of the following conditions, except A. Constrictive pericarditis. B. Restrictive cardiomyopathies. C. Tricuspid regurgitation. Or D. Cardiac tamponade.
Question 8. All the following statements about the third heart sound, S3, are true except A. Right-sided S3 correlates well with a rapid Y descent at the neck veins. B. S3 is normally heard in infants. C. S3 usually indicates systolic dysfunction. Or D. S3 correlates well with an elevated left ventricular and diastolic pressure, usually greater than 25 millimille Hg.
Question 9. During which phase of the cardiac cycle is the cardiac apex palpable? A. Isovolumetric contraction phase. B. Isovolumetric relaxation phase. C. Rapid ejection phase. Or D. Atrial systole phase.
And finally, question 10. Sensitive and specific signs of ventricular-atrial dissociation and ventricular tachycardia are A. Variable intensity of the first heart sound. B. Variable jugular venous pulse. C. Both A and B. Or D. None of the above.
All right, listeners, that was a challenging set of questions. Let's see how you did.
For question 1, the correct answer is D. The mitral valve opens when the pressure in the left ventricle falls below the pressure in the left atrium, which is represented by point D on the pressure volume loop.
The correct answer for question 2 is C. Left ventricular ejection starts before right ventricular ejection.
Right.
Remember, events on the left side of the heart happen slightly earlier than those on the right.
For question 3, the answer is B. Isovolumetric contraction is represented by the segment on the pressure volume loop, where the volume remains constant while the pressure rapidly increases.
For question 4, the incorrect pairing is D, QT interval measure of the duration of the atrial action potential. The QT interval actually represents the total duration of ventricular depolarization and repolarization.
The correct answer for question 5 is C, mitral valve closure to aortic valve opening. This period marks the isovolumetric contraction phase where the ventricle contracts with all valves closed, causing the pressure to rise until the aortic valve opens.
For question 6, the typical left ventricular end diastolic volume in a healthy heart is C, 70 to 120 milliliters. This refers to the volume of blood in the ventricle at the end of diastole just before contraction begins.
The answer to question 7 is D, cardiac tamponade. A prominent Y descent is observed in conditions that enhance right ventricular filling, such as constrictive pericarditis, restrictive cardiomyopathies, and tricuspid regurgitation. Cardiac tamponade, on the other hand, impairs right ventricular filling, which leads to a blunted Y descent.
The statement about the third heart sound, S3, that is not true in question 8 is B. S3 is normally heard in infants. While S3 can be a normal finding in children and young adults, it is not typically heard in infants.
For question 9, the cardiac apex is palpable during C rapid ejection phase. This is when the left ventricle contracts most forcefully, pushing the heart's apex against the chest wall, making it palpable.
And finally, the answer to question 10 is C. Both A and B, variable intensity of the first heart sound and a variable jugular venous pulse, are both sensitive and specific signs of ventriculoatrial dissociation, which is often observed in ventricular tachycardia.
How did you do, listeners? We packed a lot of detailed information into that quiz.
Hopefully it helps solidify your understanding of the cardiac cycle. Phew, that quiz really put our cardiac knowledge to the test. But as always, the journey of understanding is just as important as the destination.
I agree. Learning about the cardiac cycle isn't just about memorizing facts and figures. It's about gaining a deeper appreciation for the incredible complexity and efficiency of this organ that keeps us alive.
Right.
And it helps us understand what happens when things go wrong, paving the way for diagnosing and treating various heart conditions.
It's like having this behind-the-scenes look at a masterfully conducted orchestra. Understanding how each instrument contributes to the overall symphony.
Yeah.
Knowing how the heart functions in a healthy state allows us to recognize when the rhythm is off.
That's a great analogy. And just like a musical masterpiece, the cardiac cycle is a beautifully synchronized series of events, a testament to the amazing design of the human body.
Absolutely. I want to extend another thank you to London HeartbeatsZ Academy for providing such incredible educational resources. Listeners, if you're interested in learning more about the Heart Week, I highly recommend checking out their website and social media channels.
And for our listeners, as you go about your day, consider this: the cardiac cycle is incredibly adaptable. It constantly adjusts in response to exercise, stress, even our emotions. Take a moment to tune in to your own heartbeat. Can you feel it adapting, changing its rhythm to meet your body's needs?
Wow, that's a really powerful thought. It reminds us that our hearts are much more than just pumps. They're dynamic organs constantly responding to the world around us. And on that note, a huge thank you to all our listeners for joining us on this deep dive into the cardiac cycle. We hope you've come away with a newfound appreciation for this incredible organ.
It's been a pleasure sharing this journey of discovery with you.
Don't forget to follow us on Facebook, Instagram, Spotify, and YouTube for more insightful deep dives into fascinating topics. Until next time, stay curious,